Welcome to video number 12 in Physical Disabilities and Personal Care. In this particular video, we'll look at some important medical terms and understand the services and models of care that people might receive if they have unusual medical needs. One of the terms you might hear is medically fragile, or sometimes you'll hear frail or even the word brittle used to describe people with certain medical conditions. And what this means is that the person has some type of diagnosis or a collection of diagnoses that make it difficult to stabilize their health. They're medically unstable. And this can often mean it's difficult for them to be served in the community without having routine interactions with medical professionals. And it can also mean that they're at unusually high risk. For example, they might be at high risk of getting infected or at high risk of having a recurrence of a disease, such as, for example, a heart attack or a fall. Immunocompromised is a particular type of medical fragility. What this means is that the person's immune system is lower than usual. This might be caused by a condition itself, such as diabetes, or by the treatment a person is on. For example, cancer treatment can often diminish a person's ability to fight off disease. When this happens, the person is more susceptible in many cases to becoming infected. They will often get the disease more easily than others. Or we will have a worse prognosis if they are infected, meaning that their ability to recover or their outcomes might be expected to be worse. They're at far higher risk of dying or having long-term serious disability because of being ill. Another term you might hear is complex care, or a person having multiple disabilities. What we really mean is that this person has sort of a certain combination or blending of conditions that mean that they are really challenging in order to support effectively, especially in a community setting. So these people usually require closer medical intervention. For example, you might have heard about seniors who try to age in place, meaning they try to stay in their family in their own home as they get older. Sometimes they start to move into what we call assisted living facilities. Here in Mission, that's places like Cedarbrook Chateau. And these places require the individual to still do a lot of their own personal care. However, meals are provided, transportation is provided, housekeeping is provided, not really any medical services. But as people's conditions worsen, they will likely need to move into something we call extended care, such as an extended care facility like the residences in Mission or Bevan Lodge in Abbotsford. And these facilities are staffed by medical professionals who can do more than just feeding and cleaning, but can also intervene if there's a medical emergency, can help give medicines, can help with therapies, can help make sure that they execute the orders of doctors, and so forth. And so if you hear about a person being in extended care, you know that they have gone into a truly healthcare facility, and it's usually because their needs are more complex or they have multiple disabilities or progressively worsening disabilities. Okay? In community living, we have a specific service called Health Services for Community Living. These people are a special branch, essentially, of Community Living BC. They're a set of or suite of healthcare professionals who have particular expertise in supporting people with intellectual and developmental disabilities. They include nurses, including some that are private nursing firms. And you're starting to see some changes right now by the government in terms of whether or not they want these private nursing firms to provide this care, because there can be some quality control issues. So this may change. But currently, in many cases, these nursing firms are privately contracted. For example, one organization is so commonly, it's called Vingy, that people refer to them as Vingy nurses. But really, that's just the name of a company. And these nurses literally make sort of their rounds. They have a route, a number of people that they support in the community, and they go around and they help make sure that the care plans of those people are being followed, that they're up to date. They train staff with delegation of task, and they execute and report back to doctors. They execute to the doctor's orders, and they report back to the doctors on things they may be seeing. So nurses are often the executive arm or the people that you'll see who are most likely to have been associated with HSCL, or Health Services for Community Living. They also have occupational therapists and physical therapists who are specifically trained or have experience supporting people with physical disabilities and developmental disabilities. For example, people with autism often have special needs when it comes to their physical therapy and occupational therapy, and so that's an area where you might have special expertise. These people may come and actually deliver therapy in a person's home or day program, but they may also actually help the trained staff or give staff a routine that they expect to be executed. For example, stretching routines, the use of specialized equipment such as the stander we mentioned in an earlier video, and the stretching and exercise routines. They may also design special equipment for people in things like their railings or their bathing equipment, for example, a brush or a sponge, or eating utensils, or, for example, the chairs that people use in their home. An SLP may also be part of health services for community living. An SLP is short for a speech language pathologist. These people help folks to develop speech, or if they can't develop speech, to use augmentative communication devices, whether they're PEC symbols or iPads or a variety of things in combination. Generally, SLPs are usually associated with children, particularly if the idea is to provide speech therapy, because the developmental window for developing speech occurs usually around 12 years old. So if we're going to help somebody to try and improve their ability to speak, we would typically do that with children. You may also see, depending on the community, that there's a specialized dental or even mobile dental service available. So for example, we have seen dentists that would come to our homes with a specialized van with a chair in the back. And what was really great about this was that they could avoid sedating people, which is always a risky thing to do, by having the care provided in small increments, much shorter visits, and in a comfortable setting in the person's home. And they would start to build relationship with the individual, which also helped to defeat some of the anxiety the person might experience. In some cases, the dentist is a regular dentist performing out in the community, but they may have, again, special relationships with CLBC, and they may do things that, for example, allow for more time in a visit, provide for special sedation, or even something as simple as scheduling a visit at the end of the day so there's less activity in the doctor's office and so that there's less of a feeling of being rushed when the person is getting care. And of course, a nutritionist is also a part of the services that you can get through health services for community living, because the nutritionist may have to design special menus for people with diabetes or going through types of treatment or with conditions like muscular dystrophy. These are just some of the people you might encounter. There are a couple of others I'm going to mention that may or may not be specifically related through health services for community living, but you should definitely note them as important people in the healthcare team or the care team of somebody. The first person somebody mentioned earlier, and that's the technician. This may be a person who simply works for a private firm that provides the lifts or the wheelchairs that your facility uses. And this person's job is to inspect it routinely, to do maintenance on it, replace batteries, and if something needs to be repaired or replaced, they can do that. Another person that you'll develop a strong relationship with is a pharmacist. And we've talked about that in the medications module. Now, the pharmacist is probably not part of health services for community living, but you should still think of that person as being a really instrumental part of the planning and care of the individual's support, because not only do they deliver medications and do medication audits, but they also can give you advice about side effects, about the best practices for administering certain medicines, and they can be able to recognize if, for example, two different doctors diagnose two medicines that don't go well together. It's the pharmacist who will usually notice that. Other people that might be referred may be a part of a mental health support team, another group of people that may be referred through Community Living BC. Mental health teams exist in most communities, but you'll notice I didn't say mental health support teams. A mental health support team is specifically associated with people with intellectual and developmental disabilities. So any person in a community can access a mental health team, and that's literally just a part of the local health region's mental health supports. A mental health support team, with the word support, is specifically for people who have a dual diagnosis, an intellectual disability and a mental illness. And often people with mental illness may also have physical disabilities, which is why I have put this in this module. This is where it would be suited to any person who's dually diagnosed, and it could include people with intellectual disabilities who have developed dementia. So that's a particularly common thing, as we mentioned in that video. There's going to be a doctor at the head of that table usually. It may be a psychiatrist, but in some communities there is not a psychiatrist available. So it may be a family or a general practitioner, and that person may have specific expertise or extra experience in the psychiatric aspect of medicine. So this person is often going to be connected to the individual's community doctor. The community doctor is not replaced by having a mental health support team. The mental health support team is going to focus specifically on the mental health needs of the person, whereas the community doctor is going to think about the overall health. So the doctor who is part of the mental health support team must work in conjunction with the individual's usual community doctor. There will also likely be a psychologist around the table. Remember that psychologists are not medical professionals. They do not, for example, have the ability to prescribe medicine, but they can come up with things like behavioral plans or self-help activities or therapies. There'll also likely be a registered psychiatric nurse. RPN is a registered psychiatric nurse. And in the same way as we talked about the community health nurse being the executive arm or the most commonly met person with our health services for community living team, this is true here too, where the registered psychiatric nurse may be the person that you deal with on a one-to-one basis or most frequently when encountering the mental health support team. Another is a mental health worker, and you're actually training to do this. A mental health worker is really a CSW that works predominantly in the community with people who have mental health needs. So these people might come and actually help at a nitty-gritty or a frontline level in helping to execute programs or spend time with individuals, particularly those who are living independently or semi-independently. And this group of people are all going to work together in consultation with each other and in consultation with other community professionals, such as the person's family doctor, as mentioned, as well as people like you who would be working with that person in their school, their day program, or their home. Everybody works together to have a coordinated psychosocial approach to the mental health of that person. And if they have physical needs, it all gets mixed together to try and complement one another. Various programs may have different models of care or ways of administering care. One of the most common is what you and I call a group home, which is just really a staffed home. It may house 2, 3, 4, and occasionally 5 people. Each person usually has their own room, and most of what we do for people is biopsychosocial. There is a small aspect of this that is around the person's health, like their medicines, their nutrition, their exercise, but we are not frontline healthcare workers. So if people have really evolving healthcare needs, for example, if they develop dementia, or if they become paralyzed, or if their epilepsy becomes uncontrollable, then often people may need a more intensive level of medical intervention, and that is not typically possible in a group home. What starts to happen is that some agencies have found a way of making sure that they maintain kind of the best of both worlds, because moving into a very large medical facility can have an effect on a person's quality of life that's negative. It doesn't allow us to have the same amount of freedom. We have a lot more noise and activity. It feels a lot more like an institution. So what some organizations have done have created models of communal care or co-location. And basically what this is best described as is that they have situated group homes in an area where the nurses that work in those homes can go between locations with relative ease. I've literally seen examples where 2 homes were across the street from each other and one nurse was working in both of those homes, so that if there was a medical need, she could adapt really quickly. And in another circumstance, the 2 homes were back to back with a fence in between, and all they did was install a gate in the fence so that the nurse could go between the two homes. The rest of the staff in the home were community support workers like yourself. But because there was a nurse there, a medical professional there, they could be much more flexible and dexterous. For example, if a person was having a diabetic emergency, the nurse could check the person's blood level. If the person was having difficulties with their feeding, for example, or they were constipated, the nurse could consult with the doctor and intervene in a way that a CSW couldn't. Communal care is very similar. It just basically means that people live in larger groups. Sometimes I've seen programs such as one on Sussex Drive in Burnaby, where there are a bunch of small buildings around a courtyard, and people live almost in what used to be called a commune or a kibbutz, where everybody gets together and has collective meals or activities. And that's exactly what happens in places like assisted living facilities, so that everybody comes together for meals or social activities, but goes back to their rooms for privacy, for toileting, for personal care, and so forth. So you may see a variation on that in some areas as well. Some people move into, some people have home care, which means that they live at home, but nurses come and provide medical care on a daily basis or multiple times a week. They come and they visit, and they do things like change wounds or check on the person's medications, give them their personal hygiene, make sure that they are checking on whether people are taking their prescriptions and so forth. So for people who are living independently or semi-independently, home care is a really valuable approach. And you may know of people, for example, senior citizens in your family who have needed this after they've had a surgery or as they've gotten older. And this is a really common service because it turns out it's better for everybody. It's far better for the person who's living at home to enjoy their quality of life. And it also ends up saving a lot of money because it's really expensive to run extended care facilities. And as we've seen with recent events around COVID, there are a lot of health risks of bringing people who have frail health all into the same location. When they live in their own home, it's far less likely that diseases will, for example, be conveyed from one person to the next. Home share sounds like home care, but it's really not. In home share, what's happening is that usually a family has a space within their home and is essentially providing room and board for an individual with intellectual, developmental, and or physical disabilities. And the person essentially comes and becomes a part of that family. When people provide this service, they're really independent contractors. In other words, they're running their own business. And they have to go through a really careful process of being, shall we say, checked out or investigated before that contract will ever be signed. There's also a process of everybody getting to know each other and orientation to make sure that the person wants to move and will be comfortable in this new home, and that the people taking the individual in will be able to manage and provide really a good quality home for that person. Home shares are typically not associated with people who have really high medical needs. However, there are some people who are really good in our community and around the Fraser Valley and really around the province who become experts in providing care for people with high medical needs. And because this video is going to be recorded, I won't use any names, but there are specific people in our community who do this very, very well. And so there are a few select places that specialize in home share for people with high medical needs. And one of the great things about this system is that people get to be known very well. Really strong relationships are formed, family relationships, and usually one or two people are supported at most in these homes. So there's a lot of ability to flex and change as the person's needs evolve. Another model is called the mini board. And these were created quite a few years ago when families wanted to provide services for their own children, but found out that they wouldn't qualify for government funding if they asked for the government to send them money. In order to do that, they needed to create a not-for-profit society. And so they did that, but they did that with the intention of providing services just to one and sometimes two or three people. Sometimes families got together and created agencies that were just to support one person or maybe one or two that knew each other well and where families already had a connection. You may hear of these organizations with a special name. Quite often you'll hear the first name of the person and then the rest of the name of the organization might be Friendship Society or Family and Friends Society. And it's really because the person is often supported either in the family home or a suite of the home, or perhaps in an apartment that the family has purchased or oversees. And in order to do this, they create a board. Usually they have family friends sit on the board, 3 to 5 people. But the government gives them funding just the same as they would with any other not-for-profit organization that was doing this work. And the micro board really just focuses on supporting that one individual. What's cool about this, again, is that it's an opportunity for kind of a balance of professionalization. You might work in an organization like this, but really strong connectivity to family. And this is a popular model, particularly for families that worry about their children's ability to be supported after the family passes away. And one of the things they often do is they leave what's called a legacy. In other words, they have it in their will that when they die, the money will be used, and even the home or other property may be used to help continue to support their child. So without getting into a whole bunch of stuff about legality and taxes, that's a model of care that's often used that allows families to maintain oversight and connection to their child's welfare. But you may also hear about people moving, as we said, into more advanced healthcare settings. For example, I talked about extended care facilities. So let me break those down. Adult daycare is a little bit different than what you might expect. We often talk about day programs, which are programs for people with intellectual and developmental disabilities that are meant to progressively enhance their skills, their independence, and their quality of life. Adult daycare is much more like just basically providing respite to individuals, for example, spouses or adult children who might be taking care of people who have declining physical or mental health, especially dementia. So they are literally almost like daycares for children in the sense that they are providing really kind of oversight. They aren't going out and doing a ton of programming to try and improve people's independence, because people are often progressively losing their independence. But the idea is to give both the patient, and you'll notice I'm using the word patient because it's a medical facility, as well as the family, a bit of a break. Occasionally you'll see something like this for people who are doing home share with individuals who have advanced needs, but typically that's not the way it goes. And the reason is home share providers get funded by the government to provide the care, and as part of that funding, they're allowed to use a respite provider, which basically means they can hire their own, for lack of a way of putting it, babysitter. It's not the most dignified way of putting it, but they can hire somebody to come in and provide that break, whether the person comes into the individual's home or whether the individual visits the respite provider's home. So adult daycare is usually associated mostly with people who do not have intellectual disabilities, people, for example, like your own family members who decline in their mental health. Of course, the hospital is a place that's a healthcare setting. When you hear people talk about acute care, they're talking about the hospital the way you understand it. Places like Mission Memorial Hospital or Abbotsford Regional Hospital, places where people would go and have short stays generally and get intensive care. That's what acute really means. So they're going there for an emergency visit, they're going there for surgery, or they're going there for some type of day procedure. For example, they might go in there to get dialysis or chemotherapy. Extended care facilities are actually considered to be a type of hospital as well, although you don't hear that very much anymore because the focus is on trying to provide more of a home-like setting. But extended care facilities are medical facilities. They're staffed with licensed practical nurses, resident care attendants, registered nurses, registered psychiatric nurses. And while doctors are not typically on staff, they may be just a call away, or they may do rounds as part of their work there. They would also likely have access to people like, for example, care aides and nutritionists and therapists and so forth. So again, you will not be certified to work in any of the ones at the bottom. In order to do that work, you need a healthcare provider number, and the focus there is really on the physical welfare of people, whereas the work we do is focused on their psychosocial wellness. You'll also hear the term care plans and protocols used often when serving people with complex medical needs or medical fragility. These are just similar to an ISP, except that instead of looking at the overall services of a person, these are annual plans that talk about the medical care of that client. And not everybody has a care plan. If you're not in kind of unusual territory around your health, you wouldn't have a care plan. These are used for people who are medically fragile or have those high medical needs we talked about. It's not the same as an individualized service plan, but it would be a companion to an ISP. And by the way, you might hear other terms used for these, including quality of life plan or health care plans. They're really all the same things. These are rules. They really do stipulate what you must do to care for that person and what you can't do. So sometimes the specific nitty-gritty of care is called the protocols. These are medically approved. Doctors, nurses, and other medical professionals sign off on them. They include the therapies, occupational and physical, medications, nutrition, and all the other things that we've talked about. So we talked about diet. We might also expect things in there like, for example, the food processing requirements of people. Believe it or not, all those little settings on your blender mean something different to a healthcare provider. So if something is pureed, it's a different consistency than if it's liquefied. And so literally these consistencies of food and the amount of food a person is given, how it's administered, how frequently, are all part of a healthcare plan. Similarly, they may have a sleep routine that is regimented and recorded. Their hygiene care, again, how they get care, for example, their dental care, and how often. Allergy maintenance, what foods shouldn't be around them, or what medicine should they take to prevent allergies. Remember, if a person has difficulty with respiration, allergy season can be more than an inconvenience. If they have a buildup of body fluids in their breathing passages, they can die. So managing people's allergies is really important. And of course, their medications is really important. A lot of attention is paid in healthcare plans to recording what's going on with a person. So that can include their weight, that can include their bathroom, going to the bathroom, especially bowel movements. That can include their food intake. That can include their liquid intake, menstrual cycle. All of those things might be recorded for a person. And what we're really looking for is trends up or down to see if a person's got indicators that their healthcare is, that their health is declining or improving. And again, remember that the healthcare plan may actually require tasks such as the use of feeding tubes, the use of suction, the use of glucose testers, or called glucometers, injections, respirators. All these things require delegation of task, and that may also be specified in the healthcare plan. Okay, that wraps up this video. Just one left to go for me, but please make sure that you watch all of the procedural videos that are a part of this module as well.